Hello.
Hello.
Will you project the community health project slides?
Say that again? You cut out.
Will you, let me move my paper. Will you project the community health project slides?
I can, yes.
Thank you.
Do you want me to project everything?
Yes.
I'm good.
I put things in a projection folder.
Okay. We'll pull everything up here. Community Advisory Council, 21, April.
So if you're projecting, does that mean I'm tech?
Well, I can do both. You're talking, or I can do, I don't know.
Does Kelsey usually do tech?
I don't know.
Do you normally do tech?
I don't know. We don't normally do anything, which is the problem.
I normally project. Kelsey does like the minutes, but did you normally?
Probably then.
These?
I think I did help with tech, yeah.
Okay. Yeah. I guess we can talk to Kelsey when she gets here.
Yeah, that's fine. Yeah, I don't have, because I'm not doing anything in the meeting, so I'm happy to do something. Otherwise, I'll be kind of bored.
Okay.
And subject to making too much noise on my end. Close out some of my stuff.
How was Lauren?
Good. She's only going to be here for the first half hour because she was finally able to get her husband into a doctor's visit that they've been fighting for, trying to get into. But she had a number of hot topics, just lots of observations and interactions. So I encouraged her to synthesize it down to like the top 3 in 2 sentences and share those during public comment.
What are we going to do with that?
Well, I think we can talk about that. I think it'll be what we like based on, like, we're going to build some of that next week when we get together with emergent issues. I think we document it for now, and we probably ask Pacific Source to do a little bit more research and pull up some data. It's my initial thought. It's subject to change. Do we have an opening slide? Is there an existing opening slide?
I have to. Can you hear me?
Yeah.
Can you hear me? Okay.
I can hear you better
when
you face your screen. When you're not facing the screen, it cuts in and out a little bit.
Even with these?
Oh.
Oh, maybe not today. Yesterday for sure.
So what did you say about an opening slide?
I was going to tell you, go to a previous meeting, and if you copy one, you can bring it forward or just open it from a previous meeting. That's probably where one is.
You ready for this?
Who are you talking to?
Both of you.
Why would I need to be ready for this? Why? What's going to happen? It's a CAC meeting.
Yes.
Right, yeah. That's why.
I suppose my head's kind of somewhere else. I'm setting up key informant interviews for the public perception survey, so I'm trying to figure out how to do this best. Okay, interesting.
Opening slide. All right, let's copy this baby. I had to go all the way back to January. Why aren't you opening? As soon as you open.
Are you okay? What'd you do?
I jammed my foot into the leg of the table.
That's horrible.
I'm glad the recording captured that.
Oh, the recording captures all sorts of lovely things from all of us all the time.
That's funny. Funny, not funny. Back over there. Let's open up all this stuff.
I'm excited Molly's coming today.
Molly's coming?
Hmm.
Oh man, how long has it been since I've seen Molly?
Molly who?
Rolly.
From Pacific Source?
She used to be the Kristen.
Oh, yes, yes.
I will never forget that one slide that she had that was like questions.
With the
And it
horse
was a
or whatever.
horse that had gotten stuck in a fence, and it told like he was fine. He was just standing there, but he couldn't go backward or forward. And it's like, how does the horse even get like this in the first place? That's the big question.
Was it a horse or was it a cow?
I thought it was a horse, but it's been a long time.
Hi, Lauren. Lauren's logging on. She can't hear us yet.
Okay. May have a child yelling mommy during the meetings today.
Okay. Oh, that one doesn't have it.
Gwen, are you doing tech?
It appears so. Yes, I'm doing tech.
Thanks, Gwen. Hi, Mandy.
Hi guys, how are you?
Good. How are you doing?
Not too bad.
Good.
Hello.
Hi, Elizabeth.
Hi.
There are not very many of us on the line yet, so we're just waiting around to get started, but glad you can make it.
Okay, yeah, I had physical therapy, water therapy this morning, so I'm glad I got it all done in time.
Oh, very cool.
Yeah. So how are you all doing?
I think we're looking forward to the sunshine this weekend.
Yeah, that'll be nice. Yeah. Probably go walking. I'm going to put you all on mute. I've got a new phone that has a mute, okay?
Awesome. Very cool. No problem.
Okay. All right.
Hi, Lauren. Can you hear us?
Yes, hi. Oh, wait, who'd you talk
Yeah.
to?
Yeah, we
Lauren?
can hear you. Perfect. I just saw your audio was just set up, so I want to make sure you can hear us.
Yeah, you know what? I kind of forgot since last month, so I've had you on. I've been waiting to hear one of you.
Oh, perfect. Well, welcome.
Hi.
Kelsey, is Molly on the phone yet? Molly Chirali, or will she just get on at 1:15?
She's coming today. She's not here yet. Michaela, do you know if she's planning on being here the whole time?
Not sure when she's planning on logging in.
Okay. I just want to say hi to her. I haven't seen her in a long time. That's all.
I'm sure we
Okay,
all do.
thank you.
Yeah.
Okay. All right. Thank you.
Yeah. Hi, Donna.
Hey, how's everybody doing?
We're
Hello.
here.
We're here. We're here.
Hi, Leslie.
Is
Howdy.
Leslie following me around today?
Always.
I couldn't think of really anybody better, but can I just follow you around?
Love you. I know. No, you don't want to. I don't do fun stuff, really.
Hi, Ken.
Hi, Michaela.
Hi, Regina.
Hi.
Hello, hello.
Hi, Brad.
Hi there.
Hi, Brad.
Everybody. Finishing the last of my lunch here.
Oh, Molly's connecting right now. She can't hear us yet. Hi, Molly.
Hello.
So good to hear your voice.
Oh, so good to hear yours. This is
Been a
so
while.
fun.
We want to see your face. There it is.
It's here. It's right there. Look at that. All on its glory.
Good hair. Good hair.
I miss you guys so much. You wouldn't believe how I think I'm more excited about being here than anything else.
I don't know. I don't know if that could be true.
We're very excited.
Yay. Well, thank you for let's be here. I'm gonna see all these faces. I'm just like, oh my gosh, I've missed so many of you all.
Where have you been, Molly?
Oh, just kind of hiding out a little bit. I've been doing my role as the team lead for the member support staff. So I've been doing
Okay.
that now for a little over a year. It's been a while.
All right.
Molly? Hi, it's Elizabeth Schmidt. I just wanted to say hi.
Hello.
Hi. Yeah, I miss you. So,
Oh, thank you. I miss you guys
Yeah.
all too. I really do.
okay. Yeah.
I was just gonna say it's 12:02 and I count that we need one more person to have a quorum and get started.
Thanks, Kelsey. If everybody could put your names and affiliations and so forth in the chat, that'd be great.
And there's Larry, so we can get going.
All right. Oh, welcome everybody to another Community Advisory Council meeting. Hope everybody's doing well. We gotta say it feels good that we're seem to be on our way out of this pandemic. Bumps along the road, but it's feeling pretty good. I hope everybody else is in the same boat. If you haven't already, please add your name and affiliation to the chat. And Kelsey, can you help us with introductions?
Me too. I'll start with you, Brad.
Brad Porterfield, Consumer Representative and CAC Chair.
Thanks. Larry and then Natalie.
Larry Kigosic, Consumer Representative.
Hi, Natalie, Jefferson County Public Health Perinatal Care Coordinator and also Community Health Worker.
Awesome, Natalie. Your sound is just a little bit muffled. If you speak again, make sure to get real close to your mic. Elaine and then Lauren.
Elena C. Schultz, Mosaic Medical Community Member on the CAC. Sorry, was I supposed to say anything else? I got distracted
you're
for
fine.
a minute.
No. Lauren, can you introduce yourself?
Hi, Lauren Kostudik from Lapine, CAC member, OHP member, her, she, and her.
Awesome, thank you.
You're welcome.
Teresa and then Regina.
Teresa Olander, Community Rep.
Regina Sanchez, Cook County CAC member.
Elizabeth and then Mandy. Elizabeth, we can't hear you. Did you mute?
Hi, am I on now?
Yes.
Okay, this is Elizabeth Schmidt, consumer rep, and in public comments, I found out about the dental, so I'll talk about that. Thank you.
Yeah.
Hi, I'm Mandy Seeley. I'm in Sisters. I use she, they pronouns, and I'm a consumer rep.
Thank you. Ken and then Maida.
Good afternoon, everyone. I'm Ken Wilhelm with United Way. I use pronouns he, him, his. I'm a community organization rep for the CAC.
Hi, everybody. My name is Maida. I am from Madras, Jefferson County, and I am a consumer rep.
Great. I'll move through the CUHC staff. My name is Kelsey Seymour. I'm the administrative assistant and media coordinator. My pronouns are she, her, and hers. And then I'll go to Michaela and Gwen.
Hello, everyone. Michaela Arsenault. My pronouns are she, her, and hers, and I'm a project manager at the Central Oregon Health Council.
Hi, Gwen Jones, she, her, hers, also project manager.
Rebecca and Donna.
Hi, everyone. My name is Rebecca Berry. My pronouns are she, her, hers, and I am the Grants and Metrics Manager here at the Central Oregon Health Council.
Good afternoon, everybody. My name is Donna Mills, and I have the distinct pleasure of serving as the Executive Director for the Central Oregon Health Council, and I use she and her pronouns.
Thank you. And I realized I should have specified which Rebecca. I'll move to Rebecca Donnell next.
Hi, everyone. Good afternoon. I'm Rebecca Donnell, she, her, her pronouns, and I'm an innovator agent with Oregon Health Authority, and I work with the Pacific Source CCOs.
Thank you. Leslie, and then Kristen, and then Buffy.
Hi, Leslie Neugebauer, Pacific Source.
Hi, Kristen Tobias, Community Health Coordinator for Pacific Source, and I'm going to give Buffy just like the tiniest introduction. So Buffy joined Pacific Source February 15th, and she joined us from her previous position as a healthcare analyst for the Confederated Tribes of Warm Springs. So Buffy, welcome.
Hi, I feel like I don't have to introduce myself, but I am Buffy Hurtado. I am an enrolled member of the Confederated Tribes of Warm Springs, and I now hold the position of Tribal Liaison for Pacific Source.
Buffy, it's so nice to meet you. Thank you for being here today. And last but not least, who feels like our guest of honor, Molly.
Thanks, guys. Hi, everyone. It's Molly Tiroli, and I am the Member Support Specialist Team Lead that covers Central Oregon, Portland, and the Columbia Gorge regions. I also have a couple duals member support staff who cover Central Portland, Gorge, Marion, Polk, and Lane County. So glad to see so many of you guys.
Okay, did I miss anybody? Wave wildly at the camera, so.
I will just add really quick. So I have a couple staff who'll be joining for our part of the presentation, just due to the demand of what the workload. They'll come on a little bit closer to our presenting time.
Awesome. Thank you for that heads up. All right, Brad, back to you.
Thanks, Kelsey. All right. Well, I know we're going to open up for public comment. And Elizabeth, you said you had something to share.
Yeah, okay, I found out about the dental care, how to get it. And what you do is you have to be assigned to Capital, and then they assign you to General Dental, which is over by Cracker Barrel. And then they do the x-rays and all that assessment. If you need additional help, then they assign you out to Central Oregon, like, is it paradental, or when you have to have the cleaning? The person, the director of opportunities, is Deanne Lambert. I spoke with her. So you refer to Capital Dental Group, then they refer to Gentle Dental, and then they refer to the Salem area for an expert if you need it. So that's what I found out.
Elizabeth, was that for a specific type of dental service?
The initial general dental is your x-rays and all that. Then they refer out if you need a specialist, and you have to be referred into the valley. So that would involve transportation from OHP, but they will get you all the way through anything you need. Does that answer your question?
Yeah, I think so. I'm just trying to get clarity on. So, I mean, I'm guessing what you just described is not kind of the general dental, basic dental services kind of prevention.
No, it's for a periodontist.
Periodontist, okay.
Eventually. So Capital Dental Group will refer you to Gentle Dental. And that's where you get your basic care. And then they refer on to periodontic if you need it. It's a whole process. And Gianna Lambert, Director of Operations for Gentle Dental, spent some time describing all this. So it's really the process.
Well, thank you, Elizabeth. Are there any other
Thank you.
comments? Or
Lauren has something to say.
Lauren?
Yes, hi. Okay, because I've got, I can't make it for the whole meeting today. So I wanted to just to touch base and please pass this along to Kristen Tobias that what I saw her presentation at the end of our meeting today, I'll miss, but that exercise, gym membership, physical, support for low income people that cannot get a gym membership. And there's no YMCA out here in Lapine. I think is a godsend. I think it's a lifesaver. I'm not using that word lightly. It's going to help heart disease, fatty liver, diabetes, blood pressure. It's good for your physical, your mental, your spirituality. I think that is wonderful and very much needed here. I can get into more later on at another time. I love the idea that there's going to be a survey so we can maybe say, what are you guys really doing? And what is our big goal? Because, sometimes maybe I forget. And I also want to touch base and say that I've noticed with the Lapine Clinic, because I did ask him about this gym membership. I saw someone at Grocery Outlet, a cashier that looked really good, sparkling eyes and lost some weight. And she said something about this. And I said, really? And I mentioned it to my provider at the clinic. They didn't know anything about this. But I did say, could you please help me? Because this would help me tremendously, as you know. So we'll see what happens. But I really keep my fingers crossed on that. And I would thank anybody that can get this passed through. Patients at the Lapine Clinic, this is just an observation of mine. I think anybody, unless maybe they show cognitive decline earlier, I think patients over 80 years old should have their feet examined by their doctor or their PA or who's ever there, like maybe every 2 months, whether they need it or not, because I've come across people that have feet that have not been tended to, and it's shocking. So that's just something that I've kind of found.
All right, thanks,
That's
Lauren.
it.
Thanks.
You're welcome.
So you're talking about that's proposed. I know we're gonna flex fund or as a whatever it's being called now. Is that right?
Who are you talking to?
You.
Oh, okay. You know what? You blinked out at the beginning of it. Yeah, the flex fund, I guess. I won't be able to hear enough about it from Kristen, but it's something that I know back in Illinois, we did have, like with the YMCAs, and we did have some assistance. And so yes, I'd like to learn more about that. But from what I read into, I think it is a big plus for many reasons. If people want to look into it and they're serious about it, if there's an avenue for it, and if they're not afraid to go in and take that first step, I think it can make a big difference for some of these people that cannot get to Bend, cannot afford a gym membership. And so, yeah, the Flex program.
All right.
Actually, can I give some history that way back, like 4 or 5 years back, actually, the pilot for the Flex funds before it was a kind of state mandate actually started in the CAC with myself and a couple other members who wrote a pilot to have exactly funding for the gym memberships, blenders, air conditioners, things that, we know impact people's health. So it's wonderful. And I know it's in the packet, but that we talk about it over the years. And I wonder, like Mosaic uses it heavily, our community health workers, and I'm sure Lapine Community Health Center also their community outreach workers also know about it. But it has to come through the provider, which is clunky for some, but it has to be a kind of a prescription through the provider. But it's so helpful.
Thanks, Elaine.
I have a comment. Elizabeth, there's some therapy in Sun River. I think if a person can get from La Pine to Sun River, there are many services available. So that's my comment. Thank you.
All right, well, thanks to those of you who participated in the public comments for providing that input and getting back to us, Elizabeth, thank you. Let's move on to approve our minutes. Everybody have a chance to read through the minutes? They're pretty streamlined this time. I didn't see any actions in there to review, so. Somebody like to make a motion to approve the minutes?
So moved. This is Ken.
Ken.
Approved.
Somebody like the second? Who was that?
Laura.
Second, this is Larry.
Laura. Oh. All right, any comments? Let's go ahead and vote. If you'd like to just vocalize your approval or not.
Yes.
Say yay if you approve the minutes.
Yay.
Yes, yay.
Yes, yay. All right, I think we're good. Thanks, everybody. So I guess I'm next. Am I able to share my screen?
Yes, you are.
Okay. I don't have a lot of time for me to share with you about a conversation I had with the Health Council Board, but I do want to, I think it'll help if you can see my notes. So last week at the Health Council Board meeting, I asked board members, as your chair for the Community Advisory Council, what they believe the purpose of the CAC is, Community Advisory Council. And then we just kind of had a conversation about different aspects of the CAC. What is the purpose? What's the role? In particular to the board, advisory to the board, and how can the CAC be more advisory to the board? And it was kind of just a beginning of this conversation, but it went pretty well. And then yeah, I think the highlight was pretty much everybody on the board sees CAC members as the customer and believes that that's important. The customer, after all, is always right. And so they want feedback from customers regarding the services that are being provided. And then, because I keep working through, so that's Medicaid, that's specific sources essentially, but it's also, we're always thinking more broadly as well about our health system. So I think that fits into our role as consumers and customers and people who want to be healthy, want communities to be healthy. There were some, definitely the idea of the emergent issues coming up and the CAC kind of looking at those, addressing those, prioritizing those is important. So that's an important role that we're going to continue to work through. I think one of the questions I have as follow-up to that is, how do those emerging issues find their way to us? Because while we have a small number of representatives, there needs to be I think we need to talk about that, what that system is, how emerging issues make their way to the CAC. There was, let's see. I think one of the other things that caught my attention was that the board really appreciates the one time a year that the CAC and the board get together to work together on priorities and strategizing. That was good to hear. And then I'll wrap up my time with this time with one of the board members kind of turned the question back to the CAC, asking us, what do we expect from the board? It's kind of the back and forth. We are supposed to be advisory to the board, and then what are our expectations of the board in general, and then more specifically, if we do provide, in the moments when we do provide feedback to them or raise issues to them, what do we expect? And that's all. I just wanted to share that. And then I want to incorporate some of the notes that Gwen sent to me. She was also part of that board meeting and caught some other nuances that I'm going to include in these notes. And then we'll get these notes out to all of you, so you can think about them kind of offline. And then we'll bring this back in future meetings to continue to discuss. How's that sound?
Great. We'll get a copy of this, your notes. I like that.
Yes, once I add some more thoughts from others who were in that
Okay.
meeting. Yep. And then we'll
Good,
bring this
thank you.
back to future meetings to continue discussing.
Good.
Yeah, there's some follow-up questions there that'll kind of lead us into the future discussions.
We'll also be able to send out a clip from the board meeting of that discussion, so you can view it for yourself as well.
Oh, nice. All right, let's go ahead and move on to community health projects, process development.
Gwen's pulling up the slides right now. One moment.
I want to remind our folks calling in on the phone to please use your mute button when you're not sharing something in the meeting.
All right, so it is that time of year where we need to start planning our community health projects process, also known as Community Benefit Initiative. They're one and the same. Community Benefit Initiative is OHA and CCO lingo. So today I want to give an overview of what community health projects are, kind of refresh your memory, and then also do a refresh on the process that we used last year, build on that knowledge to then make decisions today around whether or not you as a CAC want to narrow the focus on that. And if so, what that focus would be, make decisions around the process for reviewing those applications, the award range, etc. So next slide, please. All right, so before we begin, I wanted to note that the CCO contract requires the CAC and the tribes to have a role in the community health projects. So we're very excited to be working with Pacific Source's new tribal liaison, Buffy Hurtado. And as we work with Buffy to build those relationships with their tribe and their roles evolve, we want to be responsive to that and be flexible with the decisions that we make today. Okay, so community health projects, they are community level projects focused on improving population health and healthcare quality. They're focused on social determinants of health and health equity, and they need to align with the regional health improvement plan. In addition to that, they're meant to improve health outcomes, reduce health disparities, promote the efficient use of resources, like I said, align with the regional health improvement plan, promote increased wellness and health activities, and improve overall community well-being. Okay, so reflecting on this past year's process. Go to the next slide. All right, so we say each year the CAC will receive about $250,000 to invest in the community. Last year, you received an extra $700,000 to invest that we weren't anticipating. And this was a percentage of the funds that came back to the community from providers. Improving patients' health as kind of an incentive, but OHA directed those funds to be used for social determinants of health and health equity. So they were added to your pool of funds. So which brought your total of investing up to $950,000 last year. Each year, the funds need to be spent by the end of the year, so December 31st of each year. As you may recall, last July, you sent out a request for proposal asking community partners to write applications of projects that they wanted funding for to improve health. You set the award ranges from $5,000 to $50,000, working under the assumption that you only had $250,000 to invest. In August, you developed a scorecard and you used that scorecard to review all applications. In September, you had made some initial funding decisions based on the scored proposals. And then in October, you made those final funding decisions. There was a lot of interest in the community health project. So you received 42 proposals. Last year, the totaling amount of requests asked was just over 1.6 million. And again, you only had $950,000 to invest. So you had to make some decisions. Next slide. So as you recall, because there were so many applications, we split you into 4 review groups, each group reviewing between 10 to 11 proposals using that scorecard that you had developed. And then during your September meeting, we brought those results back to you. We also provided information. Go back to the last one. Yeah, we brought information about which communities those projects served, as well as which social determinants of health they addressed. During that meeting, you decided to approve the top rated scores and declined the lowest ranking scored proposals. And we drilled into the middle ranked proposals to discuss further. During this meeting, you also decided to prioritize rural communities, and you re-ranked those 14 middle scored proposals, which brings you to October. Next slide. We brought those rankings back. There was 3 that tied, and you decided ultimately to prioritize the proposals that addressed housing because you felt that COVID had a bigger impact or higher impact on homelessness. Next slide. All right, so that was kind of a refresher of what community health projects were and the process that you used. I do want to kind of build on that information to then starting to make decisions around what 2021 will look like. Any questions on or comments about the 2020 process? Okay.
Yeah, I have a comment, Michaela.
Okay.
I thought it was a really great process. You guys devised a really efficient, and I thought it amazing. So that's my comment.
Thanks, Larry.
It's a big undertaking, so I would echo that there's no perfect ways, and it's hard to get input on everything. And so I appreciate that you tried to get as many eyes as possible.
Yes, it was a heavy lift for everyone. All right, so let's now focus on this next year. So for 2021, the budget is $370,000, and we do not anticipate more funds. And like all years, these funds have to be spent by December 31st of this year. Next slide. So, which brings us to the first question. So last year you decided to keep the topic broad and accept applications that met the basic community health projects criteria. So projects that address social determinants of health, health equity, and also aligned with the regional health improvement plan. So I want to have a focused conversation with you to determine whether or not you would like to narrow the focus and what you'd like to narrow the focus on if you want to narrow it. In our survey from last month, the results were split between
folks wanting to narrow it and not narrow it, but those that wanted to narrow the focus so that they want to focus on economic stability and education, those two social determinants of health. So I put some options up on the slides of ways you could narrow it. And then I'll ask you kind of a series of questions to help us kind of reach a decision or a conclusion around this. So up on the slides, you could narrow it by an area of social determinants of health. You could narrow it by geographic area or prioritize, rural communities, prioritize populations, prioritize, maybe you want to focus on one of those areas of the regional health improvement plan. What are some other ways that the CAC could consider narrowing the focus? Gwen, do you want to leave that slide up just so it has some options up there?
That'd be helpful. I have a question. Do we have any data on, like, if there are in any of these categories, geographic area, prioritized populations, et cetera, if there's any data that tells us when we think about equity, if there's any group or groups that are underserved compared to others, so that we can focus on the underserved. That makes sense?
Yeah, I'm sure there is. Rebecca, would you mind helping me answer that question?
You mean regions that are underserved?
Anything. It could be geographic. It could be prioritized, certain populations. It could be certain areas of social determinants of health. Just trying to look at the equity piece. Like, do we have anything telling us, data telling us there's gaps that we should maybe focus on, or there's underserved communities that we should focus on?
Well, last time we did that, when we were looking at the grants, it was nice to see some areas that were outside of Deschutes, because if you're not in Deschutes, you kind of wish you were, because it just seemed like there was a lot more services. So I like to see it spread out more.
Brad, I hear what you're saying, and I spend a lot of my time when I'm not in meetings trying to look at that data of disparities, and just knowing that, for example, Jefferson County has health outcomes that are a number of them that are definitely at a lower level than Deschutes County for sure. And so we can look at, and then is it for the Caucasian population, Latinx population, Native population. So then we can look at each of those health areas. One of the ones that we've looked at recently a lot is food access, and looking at our patient data in terms of by geographic, by ethnicity, race. So the regional health assessment plan, or regional health assessment, has some of that, but it is 2 years old, right, Rebecca?
But that's why we have the Central Oregon Health Data Site. So that data is the most up to date, and it can show particularly, some interesting things you'll see are just the measures in the regional health improvement plan and the differences by either town or county, and then in some cases zip code, or as small as census tract. So yeah, those are some options. And then also there's just some really great data that goes beyond the measures in the regional health improvement plan on that site as well. And it's broken up in some cases only by county, but in other cases it's broken up by, say, like neighborhood in a town. So it you can take a look at that data and kind of see where things are varying. There's actually a socioeconomic needs index on our site, and it's broken down by actual neighborhood. I'll actually put the link in the chat so folks who are on their computers can take a look at that.
Thank you.
Yep.
You know, one of the disparities that is kind of current that we've been thinking a lot about is only 3% of the Latinx population has gotten the vaccine yet. Of the tests, for COVID tests, you know, it's ranged anywhere from 16, 18% to 23% of the positive tests are Latinx population. So definitely we know that COVID has hit certain populations, and in Central Oregon, the largest being the Latinx population more than others. So that's a current equity issue. Did I do a mic drop?
It seems, yeah, it seems to me in the last process that we addressed disparities after the proposals had come in. So in other words, we favored proposals that came from some of the outlying communities away from Bend. So we didn't articulate addressing the disparities ahead of time, but did so based on which proposals we chose.
Yeah, for the second round of review, you prioritize rural areas. Also within the scoring matrix, there was a part where you ranked health equity within the proposal.
So Michaela, do you want
I don't know if this is helpful in terms of talking about narrowing the focus, but and I'm coming from a sort of a biased position, but in these times of COVID, mental health issues seem to be huge, just because of the anxiety around that. So I don't know if that's helpful to mention mental health as being something that needs to be prioritized.
So let me back up and maybe let's approach this looking at should we narrow the focus or not, and then go kind of onto the second step of if we should, what should we narrow it to, and kind of, or what do we need to, what data or sources do we need to look at to help determine that? So other ways to narrow the focus. Does anyone have kind of some other categories, and then we can talk about kind of pros and cons to narrowing?
Wait, are we first going to decide whether we agree to narrow or agree not to narrow? Or
yes, that's what we're looking at right now. Should we narrow our focus or not?
I say no, because I think social determinants of health are really a broad category, and there's a lot of different organizations approaching it from different ways, meeting different people's needs. And I think we should leave this grant open to all of them personally.
What are some other cons with narrowing?
possibly excluding?
Other thoughts on the cons to narrowing?
I remember Linda saying last year, you know, by leaving it more open, you never know what innovative ideas that actually cross sectors might come. And I thought that was a really good point, that we're allowing for more cross thinking versus keeping it really, keeping it narrower.
All right, so that's a pro.
What are some other pros? Go ahead, Ken.
I was going to offer a con. That's so I
Okay.
can wait for more pros.
Go ahead, Ken.
Con is that it
I'd be
will
swapped.
create, I think there'll be a lot more proposals that will need to be waded through, so it'll increase the workload quite a bit. And it also, I think, because of the limited amount of money we have, means that there will be a lot, either the awards will be quite small or there will be quite a few that do not get funded. So there'll be a lot of disappointed proponents.
For our folks who are on the phone, can you please mute yourself if you're not contributing to the conversation? Thank you so much.
Michaela, or actually speaking to all of you, what if we were to, so not limit any specific social determinant of health, but utilize the same kind of filters that we put on that last round of proposals, where we did kind of we focused on more rural areas. We focused on, what were the other filters we used? Where we decided, the things that we chose to help us kind of limit and narrow the proposals that we would fund. If we could like review those and see if we agree with kind of continuing to use those same filters, but not limiting kind of the types of social determinants of health or the focus areas, limiting more the geography or the other things.
And I have a quick question, I think related to that, Brad. Are we going to change the amounts? Because before we said 5,000 to 50,000.
So that's a question for later today if we get to it. So Brad, you're suggesting leaving it open to projects that focus on social determinants of health, health equity, align with our regional health improvement plan, but also focus on the rural communities within Central Oregon.
Yes. Because I do think, but to continue Ken's thought, or to add on to that, I think we do, if we can make some decisions that will restrict the number of proposals we receive, that's going to be to our benefit. We don't want to be exclusive. We don't exclude folks, but if we have like those priorities, like rural areas, this proposal will impact rural areas more than, Bend, where there's more resources. That kind of thing can at least help kind of narrow it a little bit.
We could put that filter on the request for proposals, or however you want to get that information out to the public, to encourage projects that focus on rural communities. We could also build it into the scoring of the application, so that is possible. What are some thoughts on that?
Well, not to be the bad guy, but there's a reason that there are more resources in Bend, is because the needs, the population size and the needs are much greater too. So I'm wondering about the proportionality of resources in relation to population. Does that make sense?
Mm-hmm. Other thoughts from the group?
I would say as long as grant writers know in advance that rural's a criteria, because you don't want to ask anybody to spend all this time writing a grant if our matrix is going to kick them out because they're not rural and they don't know about that. That's not fair.
If the CAC decides to go with it, that would be communicated.
Okay.
Yeah.
Cool.
What are some more thoughts about putting rural as a filter or not?
I just keep thinking and kind of to Larry's point, if we could say something like rural encouraged versus, again, I remember so many of the projects actually were regional, and some of those said that they were rural and they weren't as much. So maybe it would even encourage those that are regional to have more of a rural county bent, make sure that they're doing things. So that would be kind of an in-between.
Okay. Elizabeth, Ken, Mandy, what are your thoughts?
I apologize. I got up real quick to get my lunch. What was the question?
So the question is, should we have, not narrow the focus? So proposals which would focus on, would have to address social determinants of health, health equity, and align with the regional health improvement plan. But preference would be given to those proposals that serve rural communities.
So I agree with that. And also my personal input would be to, like, if we did narrow it at all by population, to focus on the most vulnerable populations.
Okay.
I have a question. This is backing up. This is Ken again. The graphic that you have there for this on this slide, is that to represent the saying that social determinants of health is in the middle because it affects all of the 5 smaller circles, the economic stability, healthcare, social and community contexts? Is that what that's intended to convey?
It's meant to convey that those 5 circles are the different categories, areas of social determinants of health.
Okay, then I don't know if this will be helpful or make things muddier, but the recent, what is it called, the American Rescue Act, the stimulus money, there's a boatload of money that's coming into our community in the near term. I think what I heard from is that Deschutes County has $38 million coming. The city of Bend has some millions of dollars coming. Those dollars, some of those are going to land in some of these the areas. So I would hope that we would be able to be strategic in where we direct our limited dollars to complement those dollars. Of course, that isn't all known yet. The little bit I'm hearing is that economic stability is going to be one of the big targets for some of those dollars. I have a feeling that built environment is also going to be, because there's so much talk about affordable housing and the importance of that for an economy. Childcare is another one. So I guess I would leave it with, I just hope that we'll be tracking that other information somehow so that our decisions complement other resources that are coming into the community as opposed to replicating those.
Yeah, and you can help us with that, Ken, right? You're going to be kind of abreast of everything that's happening.
No, I mean, I'll track what I can and I'm happy to share, but it's beyond my pay grade to be able to track all of that.
Well, I think that Elaine's suggestion is excellent as usual. And I wonder if we can somehow codify that or, put that as how we're going to approach this. Can you say that again, Elaine? It's about making it regional and.
Yeah, I just said rural encouraged, and then it would, I just remember one example reading one example of a housing proposal that had checked, Bend and then Crook, Jefferson, like all of them. And really the emphasis was on Bend. And so it would, even if there were rural proposals, tell people we want them to also make sure that rural is represented.
And this is Ken again. I support that, Elaine. And I want to amend my comments to say that it's not only Bend and Deschutes County that those dollars are headed towards. Crook County and Jefferson County and all the cities have dollars from the Rescue Act that are headed their way. So I didn't mean to imply that this is only that relevant to Deschutes County.
All right, so where are we at with, so it sounds like, and let me know if I'm wrong, it sounds like we're leaning towards not keeping the focus broad, meeting those basic criteria, but then also put in a filter or prioritizing projects that rural is encouraged, and also like in the proposal, making sure that at least that their project, if it's that it serves, includes rural areas if their location is in Bend, for example.
Sorry,
Go ahead, Brad.
also brought forward vulnerable populations or prioritized. I don't know if we go with like OHA's prioritized populations or how we would go about that, but I think that should be a factor as well, which Mandy brought forward.
All right, so vulnerable populations, we would need to define that a little bit more. What do folks think about including that as well?
Well, that's what we're always about, isn't it? I mean, that's what we're totally about.
Other thoughts?
Mandy has written in the chat suggestions, including those struggling with addiction, homelessness, mental health issues, and poverty.
All right, thoughts on vulnerable population and what that means?
It's kind of can be a tricky thing to say it means exactly this, and then people say, but you forgot this and this person, and so I'm trying to remember last year, it felt like all the grants we got, almost all were about vulnerable populations without saying that, and without having, I don't, can anyone remember? I mean, it was either kids or you could say, any age kid is a vulnerable population, but those in poverty, you could say more, or older adults, or, different ethnicity groups, or homeless, those unhoused, addictions, like has been said.
I think without even thinking about it, we, towards the end, when we had to scale down the ones we hadn't picked, we kind of kicked out the ones that weren't for vulnerable populations. Like I remember some core housing or something like that. That was more about sustainability and things like that. So I think we just naturally being the CAC and working with for lower income people anyway, and being lower income ourselves, we tend to gravitate to vulnerable populations anyway. And those are also the people that need the grants, really, or at least are trying to get them from us. I think we did it naturally, didn't we? I think we did.
Yeah.
And naturally, I think part of it was maybe just by saying focusing on equity and social determinants of health, because that narrows it to those most affected by health barriers, which means vulnerable populations.
That's right. You're right.
All right. Do you think you're ready to kind of make a decision? Would someone like to make a motion, put out a recommendation?
I move.
Yeah, I'm
So what-
sorry. I'm sorry. I'm still not clear. I'm still not clear that we've defined vulnerable populations. I mean, as I said, I think that's all that we do. And if people are asking for help, it's usually because they are a vulnerable population. But do we want to be more specific than that, or?
Well, I think vulnerable populations, it's like a really broad thing. And it's really more of, okay, so we are saying vulnerable, but what are their needs of those, categories in a way? Does it make sense? Kind of what I just tried to explain.
No.
Okay, so we're talking about meeting, trying to give access to vulnerable populations. So those would be, and it's a really broad thing because a vulnerable population can be people at risk for what, right? Again, there are different risks. It could be poverty, it could be mental health, it could be homelessness, housing, but what are those needs of each one of those that we're trying to, help out with?
So are you saying we shouldn't really define it very specifically, but keep vulnerable populations pretty broad anyway? Because it
Yeah,
is?
not really filter it down, because then I feel like if we filter it down too much, then we're excluding.
Yeah. I'd agree.
Yeah.
All right. Elaine, would you mind stating what your motion is?
I thought you were writing it down, Michaela. You would summarize it for me. So basically, it's to have our grant focus be social determinants of health, equity realm, with encouraging efforts from rural parts of the region. And you guys will make it sound better. So I would move to have that as our broad.
And I second.
Is there anyone opposed or any more conversation?
So we're encouraging rural, we're just not requiring it. That's the question.
Yes, I guess that was my idea, to kind of be in a middle ground so that we don't exclude, but we push people a little bit towards that direction.
Okay.
And I don't think we need to change the motion. I support the motion. But Gwen used a word in the chat that I think is helpful when talking about vulnerable populations, and that being that there are barriers to folks accessing services. So that's one way to think about vulnerable populations.
Any other comments or?
Ken, was that a second?
You already had a second. I think Larry jumped on it.
Oh, thank you. I missed it.
Are we ready to vote on that? All those who approve the motion, say aye.
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 Hey,
Anyone opposed or approve? Okay, I think we're good. Thanks, Michaela,
Right.
and everyone.
Yay. Thanks, everyone. Now we're going to move on to the next question for you today. But we only have 15 minutes left, so we may not get through all of it. All right. So the next decision is around review process. So during our reflection back in December, you, the CAC, expressed interest in reviewing and scoring all the applications instead of splitting up into small review groups. However, you also expressed that reviewing 10 to 11 proposals was a heavy lift. But before we make any decisions, I want to share with you a different way that we could review proposals. We go to the next slide. So last year, you sent out a request for proposal. So you sent out an invitation to the community for them to fill out the full application, giving details about their project. And with that, with an RFP, it takes about, from the time we release the request proposal out to the community, it takes about 3+ months for us to receive those applications back and for you to review them. And as you remember, those applications were very long and they were very detailed. And they were, burdensome for the applicants. If they were not funded, they put a lot of work into them. And also it took a lot of time for you, the CAC members, to review them. So another option that we could use this time is called a letter of interest, and it's slightly different. So you would release this letter of interest, inviting folks to apply to fill out kind of a shorter application, and it's just kind of an overview of the project that they're looking to fund. It is less burdensome on the application just because it's that kind of quick overview of that project. And you would review those letter of interest, those short applications, those detailing or kind of providing the overview of their project. And then you would invite those that you're serious about funding to fill out the full lengthy application. The questions that the applicant fills out, they would also be populated into the full application. So they don't have to fill out the same question twice. The downside to that is that since it's kind of two sessions of review, it's first reviewing that letter of interest, and then asking them to fill out the full application for those that you're interested in funding. It's 2 review cycles. So it takes 4 to 5 months plus from sending out the LOI, the letter of interest, to funding. And your initial decisions are based only on that high level overview of that project. So pros and cons to these 2 options. Questions on that, on what they are, what they mean?
Well, as usual, I think you guys came up with another great idea. And I think that I understand the drawback of lengthening the time, but it does seem to make it more efficient. So I would kind of go for that.
Questions around clarity about a request for proposal or a letter of interest?
Can I ask a question of last year's? Because I came into the process, I think, in the middle. Did you guys get a bunch of applications, you staff, that you went through before you gave us like the next round, so to speak? Or did you just give us everything you got last year?
We gave you everything that was submitted. So you saw all the applications.
Okay.
The only thing we look for in advance is if they're actually eligible for funding. They're not going to spend the money on something that they can't. That's the only review they go through before they get to you guys.
Okay, thank you.
Yeah, I'm seeing comments, positive comments in the chat, supporting the LOI idea. I definitely support the LOI idea. I think it would be
Okay.
Smoother and just less time on those really detailed, the more detailed proposals.
Okay. So it sounds like you're already in favor of an LOI. Anyone kind of have other thoughts or opposed?
I don't have an opposed thought, but just to share one other, and maybe it's already on there and I just am overlooking it, but it speaks to that question about we may get some innovative options that proposals that otherwise we might not encourage with us taking a broad approach to the focus, not having a narrow focus area, and then having an LOI.
That would be one con. Any other thoughts?
Well, you could write into the invitation for LOIs that there is a focus. Can you, or can you?
Mm-hmm. Yeah. So what goes out to the community will be detailed out, what projects we're looking for. Okay. Is the CAC ready to make a motion on this as well?
My only thought is LOI is perilously close to LOL, but that's.
We'll be sure to spell it out.
I would move, this is Ken, I would move that we adopt the LOI approach, the letter of interest in RFP approach.
I would second that.
All right, thanks, Ken and Teresa. Any other comments, discussion before we vote? Questions? All right, let's go ahead and vote. Signify aye if you approve. Or yes.
Aye.
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 Aye. Any abstentions or nays? Okay. Thanks, everybody. LOI it is.
All right, thanks. So we only have about 5 minutes left, but last decision for today that we had planned, which we probably won't get through, was determining an award range. So last year you set the award range between $5,000 and $50,000. This year you have $370,000. So maybe in these next 5 minutes, some initial thoughts on how we should set the award range. Maybe talk about your experience last year with pros and cons with setting it to $50,000.
Yeah, this is Ken. I've got an opinion on everything today. I would think that the $5,000 range is too low, that with the mini grants and other things, that there's plenty of opportunities for folks to get small grants like that. I'm not sure what the magic number is, if it's 10,000 or something above that. If we did 50,000 as a limit, that would mean we could fund basically 7 proposals. So if all the ALS for the mechanism. So I'm thinking 10 to 50, but I'd really like to hear if folks have other suggestions on range.
I would recommend the higher range than 50,000. I think sometimes to have a really solid quality proposal, you need to increase that amount a little bit more, maybe more like 80,000, maybe 20 to 80,000 or something like that.
Did we
thoughts on that?
Did we have any, I don't recall, did we have any proposals on the lower end in the 5,000 range last time?
I remember there being one that was very close to 10,000, if not below it. The rest were 20 plus.
That's correct. There was one that was around $6,667.
So I could certainly support Tom's approach there. 20 to 75 is a round number, to folks can remember. The one other clarification that became an issue last year is whether we're talking about proposals that are for 1 year or proposals that are multi-year. And again, with these just that we were clear on whether or not we're asking for that. The scale and amount of money we have kind of speaks to that. If a 75,000 is the top, that would be at most 3 years at $25,000 funding. I don't know that some projects need to be longer term, but I'm not sure that it's difficult to compare proposals that are for 1 year as opposed to 3 years, or especially if I just want us to be clear on the letter of interest and the RFP that goes out with that those are either encouraged or not allowed.
What do folks think about multi-year projects or allowing multi-year projects?
I think if people think they can get multi-year out of 75,000, then, they should be allowed to try and apply. But I guess we would just make the decision based on what comes in and not preordain it necessarily.
I think the types of projects last time were so varied, and some were focused more a year and some were multi. So I would hate to restrict that unless it hampers the administration of those funds.
Also, remember, we had a lot more money last year. And part of the reason we dropped to 500 or 5,000 was because we had so many applicants. We wanted to try to spread it out.
So we have about a minute left.
Oh, shoot.
Some more thoughts on multi-year. What are we thinking about allowing multi-year? It sounds like we're in favor.
So making it an option, that the max for the multi-year would still be that top number for the entire grant period, right? But if they want to divide it into 2 or 3 years, we're saying we'll consider that, right?
Mm-hmm.
Yeah. I just wanted to ask one other question on the range. What is there a significant benefit to moving the bottom from 5 to 20? Because I can see, are there pros? I can see cons, more cons than pros, personally. So I just wanted to kind of put that back out there. Is there a good reason to move? I see the moving the top end up. I get that. I don't entirely get moving the bottom end up.
Yeah, I would agree with you, Brad.
I guess I would propose to just move the bottom back down to 5 to 75 to allow for some, because we just don't know. It's again, it's the exclusion, trying not to exclude projects that, maybe there's a cap, something, equipment or something, I don't know, who knows, something it's not about personnel. Anything that involves personnel, you can't really do much for 5,000, but if there's, if it's not a personnel based proposal, then sometimes those lower amounts fit better. So it's proposed 5 to 75 be the range.
Okay. All right, so I am out of time, but we can pick this conversation back up at the next CAC meeting. And I'll keep the notes and we can reconsider kind of all the suggestions that were put out today for award range. All right, thanks everyone. You made a lot of decisions. And we got pretty far today, so thank you.
Thanks, Michaela. Yeah, good job. Everyone, we'll move on now to health-related services overview with Molly and Kristen. Take it away.
Okay, so let me see if I have. So we have Dawn on the call and then Devona. Is Devona on the call? There she
Molly,
is. Yep, there you are.
Did you want us to project or are you projecting?
Yes, you have the, do you have the presentation? Okay.
I do. Yeah, just wanted to confirm.
Wonderful. And then do we have Christina Winker on the line as well. So first, thanks again for letting us chat with you about the work that the member support specialists are doing and also in conjunction with our health related services. First, I'm going to let Devona and Dawn and Christina introduce themselves, and then we can go ahead and start our presentation. So Devona, would you kick us off?
Sure. My name is Devona. I'm a member support specialist at Pacific Source, and I specialize with the duals team.
Great. Dawn?
Hey everybody, this is Dawn Fry, and I am a member support specialist here in the Central Oregon region with Pacific Source.
Okay, and then Christina.
Hey, my name's Christina, and I work on the health related services Flex Funds team. I've been doing it since the very beginning, so this is kind of my world. Member support specialist as well, like everyone else, just kind of have my specialized area. Thanks.
Great. Alrighty, so back to the presentation. Thank you. So just to kind of stage a little bit, so the member support specialist team, so what used to be a team of, at one time was one person, we now have 14 MSSs. We have 12, we've just offered a position to our 13th, and we're working on getting our 14th hired. We are covering the Columbia Gorge, the Central Oregon, and Portland regions. We are working with a lot of our members in many different ways. And I just think it's really exciting just knowing, who the CAC is, really wanting to highlight the work that we're doing in this space. I think it's awesome for you guys to know that this is happening within the CCO and also having that awareness. So as you're out and doing what you do on the CAC, knowing the work that we're doing and be able to, let people know that this is a resource available. A lot of our members don't know about this resource, and some of our providers don't know. So we love the fact that we can, always, collaborate with our community partners. So that includes the CAC to let everyone know what we're doing. So I'm going to go ahead and Devona is going to take the first couple slides, excuse me, and then Dawn will take the last couple portions, and then we will have Christina speak about flexible funds.
Thank you, Molly. As a member support, we do help people connect to community resources. So we'll connect them to housing, food, transportation, and utilities. As part of the duals team, I work with the people who have Pacific Source Medicare, Medicaid in all regions. So what's really nice about that is it gives the members one person to call and one person to talk to, because sometimes Medicare and Medicaid don't really talk to one another. So it's a way to sort of get them to talk to one person. What I tell people is that as a member support, we might not know the answer, but we at least know how to get you to the person who knows the answer. We do hold, our nurses on our teams do hold face-to-face meetings with our members, which they have found very profitable. We also hold with our members that qualify what we call IDT member meetings, where we get the provider, APD, home health, and everybody else involved in the member's care together and the member to discuss their care and see how they could help. So this is something that we've done really well. And on the duals team, we were sort of the pilot program for Unitas, and that's been very positive.
Okay. And then let's see, did you run through the second slide too already, Devona?
No, I was going to have Dawn do that.
Okay. So Dawn, could you, so I'll have you talk about the second slide and then anything else to IDTs? You're on mute, my dear.
Sorry.
It's
It's to help keep my dogs quiet. Thanks everyone for having us here today to talk about all that we do. Devona pretty much hit everything that I was going to talk about. So I'm sorry if there's any duplicates here, because I had a fun little spiel. So we work with our members, in a wide variety of ways. We connect them to physical, behavioral health, and dental providers. If they have any barriers to care, such as transportation issues, food insecurities, housing, utility needs, then we work with them to get connected to those local resources that can help them. And we do work alongside our local providers to offer case management to help support our members to get engaged with their providers. And so what we do is we get the care teams that are wrapped with the member in what's called the IDT, or interdisciplinary team meetings. So we get the primary care provider, behavioral health, our nurse case managers, our member support specialists, our pharmacy team within Pacific Source, as well as any other support team that the member works with. For example, maybe they have a case manager with aging with people with disabilities, and they have caregiving supports, and there's just a lot of issues that we just need to all come together, get everyone on the same page, plan a care. So when we do this, we ensure that communication is consistent with all parties all across the board when communicating with a member. And so that way they understand exactly what the plan is and what is expected of the member, as well as the providers. It's always a pleasure, helping our members, especially when they say, wow, my insurance cares so much that they do all of this. I hear that so much daily. It's amazing that so many of our members just think that, we just pay their bills, their claims. But we do so much more. And it really puts a light place in my heart to be able to work with them and, getting them connected in all the ways that we can.
So Dawn, what's the process? How does somebody get a representative? How do I get somebody to help me work out my life?
Well, two ways. There's our phone number. You can always call the number that looks like it's listed here on the screen. So our email and our phone number to reach out to us. Please, don't hesitate to reach out to us in any way. If we don't have an answer, like Devona said, we definitely know someone who does. So
do you get a sign? Like, would I get assigned one of your member or one of your staff that would work directly with me, or do I get passed around a lot? Because I know that email generally goes to everyone that works there.
Sure. So we do have what we call an alpha split. So for example, myself as a member support specialist, I am assigned a nurse case manager, and we have a certain alpha. And so every MSS on the team has an alpha along with a nurse case manager, and we have access to behavioral health as well. So depending on what the alpha is, that's who your case management team would be.
When you say alpha, are you talking about the alphabet of your name?
Yes.
Thanks.
Oh, okay. So we're just divided by.
because
Okay.
there's so many of us. And, you know, I mean, back in the day, there was only 3 of us and we took care of everybody. So now we're able to kind of spread it out a little bit so that we're able to have more of that connection, that one-on-one. And so it works out really well.
We have our specialty groups as well. So we have our physical health member support specialists who are all paired with clinicians. We also have our behavioral health and member support specialists who are paired with the behavioral health clinicians. We also have our 2 dual member support specialists who are working directly with our Medicare and Pacific Source Medicare and Medicaid insurance coverage. And then we also have a member support who focuses directly with our foster kiddos. So we are broken up by specialty. So we have our behavioral health and we have our physical health. And we do definitely try to keep our members with the same people. So we've developed that alpha. Dawn is, for example, A through G of folks that she is working with in the physical health space. So and then we also have, you know, kind of our SU or our behavioral health broken up by children and adults as well.
Okay. Cool.
Is there a success story that I could ask Devona or Dawn to share?
Sure. I have one where a member came from Washington to visit her son prior COVID and then got locked down with COVID. And all her providers were in Washington and all her prescriptions were in Washington. And because of how it works, you're supposed to be assigned to CCO and stuff like that. So we were able to get her on our plan, but until we got her on our plan, we were able to do some special things where she could get her prescriptions filled in Oregon. And this is all before the telehealth really started. She could actually see her doctor in Washington, and the Oregon pharmacy accepted the Washington prescription. And we were able to get her all wrapped in care. And so by the time she actually officially moved over, she was already wrapped in care.
And Dawn, do you have one you'd like to share? Sorry to put you on the spot, but you know, we just have so many great things to share.
I know, and I am drawing a complete blank right now. I'm so sorry. If I would have had more time to prepare, I'm sorry.
No need to apologize at all, but we definitely have a lot of success stories with getting our members connected, you know, not just to community providers, but, you know, to resources that they're needing, whether that be firewood, propane, food, employment, you know, name it. There's really nothing that we cannot be helping our members with. So I really do appreciate being able to share with you more about what the member support specialists are doing. Is there any questions from this group for Devona or Dawn or myself?
What's your caseload at just a ballpark figure per person, per customer service? Because you said there used to be 3 of you, so now there's 14, but I can imagine there are a lot of people that are your clients.
Yeah, well, our caseloads definitely do fluctuate a little bit. Sometimes they kind of sit more in the 40s and 50s range. Dawn is doing all of our IDT meetings. So she's really, you know, working with the members and their providers on a little bit more of an intensive level space. And Devona is also doing that as well with her duals member. Typically we do run, you know, fairly, you know, to me, that seems like pretty good little caseload when we're looking at, you know, 40, 50 members. And these are usually folks who are needing a little bit, you know, more assistance, longer term in finding some needs and resources. So that's I would say that's pretty average. We are going to be doing a pretty big lift on our team. So we are going to be making outbound calls to our members to help them with getting registration for COVID, the vaccination. So that is a big lift that our team is going to be doing, hopefully starting by tomorrow. And we have many people involved within Pacific Source involved in this, but the MSS team will also be coming in, you know, flexing their muscles, helping out with those calls as well.
Okay.
Well, thank you guys, the member support specialist team.
Brett, I just wanted to say hi, Molly, and good to see you again. This is Larry.
Hi, Larry.
And thanks again for all the continuing great work that you guys do. You guys are amazing.
Well, thank you so much. And so Christina can just give a quick, her deal on flexible services, and we can be out of your hair.
Yeah, Molly, we're out of time.
Oh gosh, I'm so sorry. Okay.
Go to 1:30.
you.
We've already had several of our CAC
All right.
members drop off. So can we bring back the Flex Fund folks to our next meeting?
Absolutely.
All right.
Sounds good. Yep.
Thank you.
Thank you.
Just as
Bye.
long as I know, I'll be here.
All right, well, thanks, everybody. Is there anything else we need to cover? COHC staff, CAC staff? We're good, yep. Okay, thanks, everybody. Enjoy the rest of your day. Bye-bye.
Thank
Okay,
you.
everyone.
All right. Okay.
I'm gonna jump off, and Donna, I'll see you on the phone.
You said you had questions.
No.
Okay.
I just haven't gotten off yet. Sorry.
Okay, no worries.
I'll have to organize, or I'll have to call these guys. I've found it's hard for people to get back, but mine has a lot of psychological issues. I just get so burnt out by stuff, and then I make it a bigger thing than it probably has to be, but I can't help it because it just totally physically and emotionally upsets me like I'm a big baby. So I need an advocate for myself, but that's a weird thing for me to ask for. You know what I mean? Oh, am I talking to myself?
No, you're not.
Oh.
We're listening. We're good listeners.
Well, often I mute myself and I don't even realize I've done that. Yeah, I mean, I figure if I can figure out how to navigate this within the system and really understand the system, and not get really upset, it's so stupid. I sometimes act like I'm 3 or 12 and throwing a tantrum. Because I've just been told the same thing over and over again, and I feel like I'm getting nowhere. So hopefully these guys will. I've been down this road before, but it was kind of a fluke. I got connected with them because they were calling OHP members who they had sent surveys to. And I was basically put in my survey the same thing I've told you guys over the year or whatever. So I got a call and I was like, wow, who are you? Why are you? But then I had the same system and it just frustrates me. Like they say they're going to call me back, but then they don't. And then another week goes by and it was my birthday and there was no way I was going to talk to them because honestly, I cry, I get anxious. It's just this horrible thing every time I talk about it, and I'm about to do this again. So please forgive me in advance. And I just can't help it because it's just built and built and built. So I just, and then I didn't hear from them. And then I got a message that I really couldn't understand. And then I got a letter that said, we can't get a hold of you. And it's like, and then so I act like a 12-year-old and go, well, you didn't try, so screw you. And then I have to get myself back to adult stage and back up to being able to deal with the whole problem because it feels like a huge project for me. And it's just like getting a dentist. It's so stupid. And in the interim, my teeth get worse and worse and worse. And so I'm figuring if I can navigate the system and figure it out and really get it to work from the bottom up instead of the top down, because these people work really hard. You can tell, just like you guys work really hard, but as it gets filtered down, I think it gets there's just so many factors. I mean, if you look at me, you've got factor one, just like 12 different factors just to deal with me. And I'm only one person. And, you know, everybody has a huge case management or a lot of people. So trying to figure out how do I make it work for me that makes it work for everybody without just giving up. So that's me crying to you guys today. Wah.
Is there anything that we could do to help you?
No, I mean,
or
I understand this process more, but I think if I just set out, I wish things weren't general, you know, like this general email, because remember I said somebody called me, it was a fluke, they were asking me about a survey. Well, I ended up asking them about this phone number because somebody had given, I think Christina had given it to me and what it meant. And she didn't know, but then she called and looked it up and it happened to be her group that she worked with, the MSS, you know, and then I asked her, I sent her an email of my my grievance with Pacific Source against Capital and Gentle Dental, all written out because I spent weeks on it trying to get it very detailed and making sense and not being whiny. And it went to general people, which I wasn't thrilled about that. But that's part of the system. So I'll figure it out sooner or later. I appreciate you guys for wanting to help. I just don't have an answer. Anyway, do you feel like we're getting somewhere in the CAC of kind of making things really work for people? Because
I think I'm excited to have that emerging issues process so that we can actually take these issues and push them to, you know, where they need to be resolved at, instead of, you know, collecting them and now we need to do something with them.
Okay. Because you guys have, how long has the CAC existed? And you must see progress, right?
On different issues, it's been a little hit and miss, but I think like with this, developing this process is going to be fun. Like the issues that come up are going to be front and center, you know, whether they go to Pacific Source or our board or the Oregon Health Authority.
Okay. And having a system that helps sort of streamline it a little bit more.
Yeah, and having a process for following up on those.
Okay. Cool. So sometimes I'm just overly frustrated. So I apologize for that. But
don't be.
Okay, I'm gonna let you guys go back to work. Thank you.
Absolutely. Good to see you.
Yeah.
You want to stop recording? I think you're the host now. Yeah, I think Gwen made you host when she left.
Stop.
Michaela.